my goal when I was given this topic was, I think, kind of like the goal for the whole morning is to give you information and maybe perspective, not to try to make you a care provider, but to make you capable of having good conversations with your care providers, right? Whether that be a surgeon or a nurse or a geneticist or endocrinologist. So I tried to pick on some themes that I thought would be useful that you may have heard a little bit already this morning. Maybe I'm going to put them together in a slightly different way. So I have three major sections to my discussion: surveillance and screening, which will be probably a little bit different than what you just heard. A major section I have is what kind of care do people require after surgery from a medical point of view? And this is kind of that over that long term, for example. And a little bit on non-surgical care that might, again, fall into the realm of the endocrinologist and related disciplines. So one key thing is guidelines. Did you hear the expression this morning that guidelines are just guidelines? Yeah. I think it's really key because when we look at the evidence behind the guidelines, these are written by experts who are trying to make insightful and informed opinions, but they do require interpretation and individualization, which is a key theme. There's a couple issues that we struggle with a bit when we look at these guidelines. For example, you heard a lot about what do we need to know when. And as alluded to by the last speaker, some people would, if recognizing that some symptoms could develop, are okay with that. They'd rather kind of wait for a certain symptom to develop because a certain problem, like a parathyroid problem, wouldn't necessarily be the end of the world if I waited for a symptom to develop. Whereas other people aren't comfortable with that approach, or maybe the issue is more of an issue where the symptom would be kind of a late sign of the problem, maybe in the case of the pancreas, and they'd rather be more aggressive in their screening. Risk to testing. I don't know, we just heard a lot about questions about risks of genetic testing, but I think people are more and more aware these days about risks of, for example, radiation-related exposure with testing. We hear a lot about that in the medical literature, and this is not something that we're shy about dealing with. We think we're blessed to have these tests, and yet we should be including that as part of the conversation. Well, how do we feel about this test as it relates to risk of the test? Radiation being an example of that. I think a key thing that sometimes I see missed is the idea that the test is kind of the end of the evaluation. A lot of the tests we do are screening tests. By their very nature, they're not meant to be proof positive or the final answer. They just tell us we have to do more. And some people get a little bit frustrated when we say, okay, now we have a positive test, now you have to have more tests. Well, that's a very, screening tests by their nature are usually meant to try to pick up but maybe not fully clarify a problem. So some people who don't feel comfortable with more and more and more tests, we have to think, should we do the screening test? Because it certainly could be more testing, including false positive tests. So how do we actually do screening and surveillance? You heard about genetic testing, and I'm sure you heard a few of these ideas this morning already. We try to exploit these themes that we can use with these tumors. Endocrinologists like hormones, for example. So we like to exploit the fact that some of these tumors make too much hormone. So your care provider may ask you lots of questions about symptoms that could reflect too much of that hormone, for example. Or they may do a blood test for the same reason. So in the case of the pituitary, prolactin is a very easy blood test to measure. But we also might ask you about things like, women especially, are you having any unexpected milk discharge from the breast? In the case of the parathyroid, we might measure a blood calcium or a parathyroid level, or we might ask you, have you ever had a kidney stone? So exploiting the fact that these overproduction of hormones might give us signs or symptoms or blood tests that we could use to pick up a parathyroid tumor, pituitary tumor. Some tumors don't release a hormone that has any function, but normally release some proteins from that tissue. And when there's a tumor, they release more of these proteins. Calcitonin is an example from the thyroid gland, for example. There's some proteins that a pancreas tumor might make in excess of. The protein itself doesn't cause any damage or any harm or any symptoms, but we use it as a sign of too much of that tissue, perhaps a tumor. So we exploit this. Now, certainly tumors can present with a lump. So on the physical examination, or we might ask you questions about, have you experienced this kind of symptom? Do you feel anything in your neck? Do you feel anything, for example, in the groin? Thyroid is a good example of this. Some glands are in places, the pituitary is the best example. There's not a lot of room up there. So if something is changing, a lump is growing, that lump itself might not be causing a problem like producing a hormone, but it might be pressing on healthy tissue and causing an issue there. For example, the nerves to the eyes. So we might, again, be doing eye examinations and things to screen for these. Some just grow and are not apparent. And this is our biggest challenge, I think, is that tumors can be present and growing and we may not know because they don't have any symptoms. That can be a mixed blessing. So In summary, I'm screening for MEN1. This is a table you'll probably see many, many times. It'll get updated time and time again. My point in showing the table was to, again, kind of come back to my initial remark. It's a guideline. So you and your provider sit down and we look at these things and we say, well, we have a couple different ways of screening for this. We have a couple different time frames we can consider doing this. How does this fit you? And how does this fit you now? A common theme is that maybe we start to screen a little bit more closely when there's maybe some abnormality. Maybe it's not a convincing abnormality, but it's a little bit off. Well, let's check it a little more frequently now. The same can be true of some tests where we say, it's been stable for quite a while. You're at a certain age, that's not likely to become a problem. Maybe we can screen less often. So this is not meant to be a rigid thing where your doctor says, I have to do this at this certain interval. It's a guideline. It's a guideline. I only have 2 slides on MEN2. It's a slightly different situation because here, knowing what the genetic situation is makes a big difference in how we might screen people. So in MEN1, the challenge is that people might have the same gene problem, but one person in the family has this set of problems, one person has this set of problems. When we have MEN2 and this RET oncogene mutation, it does tell us a little bit better about what kinds of problems a person might experience. So again, a guideline that's provided for this might tell us differently about when we should start looking for an adrenal problem that Dr. Farley would be managing, for example, or a parathyroid problem that we might be picking up with a calcium issue, because the mutation tells us we should start looking for it sooner than later. So it's a little bit of a different thing. If you happen to meet people with MEN2 or read about MEN2, you might see them talking a lot about what mutation they have and how that made a difference in how they approach their screening, and that's why. Questions about the guideline issue? Because again, I find that sometimes people feel like that's an absolute versus again, just a place to start. Cool. Care after surgery. So I wasn't here this morning, but you got to meet a lot of great surgeons who do a key part of the aspect of care here. We haven't yet figured out how to fix the gene. So more or less now we're still developing, the situation of the gene has caused a problem. How are we going to fix the problem? So a key thing that I'm involved with is when now we've had the surgery and hopefully very successful in terms of now taking care of that particular concern, what kind of care does the person require afterwards? In the case of these situations, well, one thing we're trying to do, of course, is to see, does it come back? Sometimes the surgeon will tell us this. They'll say, well, I didn't take all that out. So commonly, for example, a neurosurgeon is very careful about how much pituitary they take out. They don't want to take out too much. Sometimes they tell us, well, I don't think I got all that tumor out. Well, let's monitor that. Other times, they're the sorts of tumor that could come back on their own. It's very similar to that screening and surveillance thing. Probably just a little bit more intensive, a little more frequent, because especially in the early days, we're looking for things to come back, and then as things are stable, maybe less frequently. Second thing we're doing as well, these glands are there for a reason. So if we take them out, and especially if we take more than we want to out, or if we have to take them all out in whatever gland we're talking about, we may have to look for hormonal deficiencies. The good news in endocrinology is that we have a replacement for almost every hormone. Parathyroid is almost the last one left, and it's coming any month now. So kind of a neat thing that most of the hormones that we have, we don't do it quite as well as the body does it. I wouldn't want to suggest that. At the same time, if we have to take a gland out or all of a certain type of gland out, we have some good treatments for that. Thyroid's a good example of that. Other issues might be more partial. I think the pancreas is a good example of this. The pancreas is an example where some people might be really kind of stressing their pancreas already. Diabetes as a concern, for example. Maybe their pancreas is making lots of insulin to help them kind of deal with blood sugar with their weight being kind of high, for example. Well, if we take out even part of it, that may be part that they were really using, and so they may find that that's going to become more of an issue after surgery. Maybe we need some medication to help fill that gap. Some hormonal deficiencies can be delayed. The best example of this is people who have radiation therapy, most commonly for the pituitary issue. So they have the radiation therapy, things are fine, and even 3 and 5 years later, we start to see some drop in thyroid level or drop in cortisol level. Now, something we talk about right up front because that person needs to know that they need to be followed. If we do this, they can't assume that just because things were good 6 months or a year later, they're going to be good. In fact, it's very common that if we're going to see it 3 to 5 years later. So it's fully discussed, but again, it can be a little deceptive because of the delay in time to which it occurs. Some might be temporary. We actually kind of like when the patient comes back from Dr. Farley's hands and his patient's calcium's a little bit low and the parathyroid hormone's a little bit low because we have a little bit more time before maybe that grows back to the point of having more trouble. But in the meantime, we may have to do a little bit to shore up the calcium level in the meantime, just while we kind of wait for that remaining tissue to kind of kick in and grow a little bit more. So it could be a temporary problem after a surgery. And some might not matter. Pituitary is a good example, but also adrenals, for example. We don't have to have all that tissue, and some of the hormones at certain stages of life don't matter so much, especially if the person feels fine. So we might just be talking to the person and say, well, this is what this hormone does, but how do you feel? And you're like, I'm good. We're like, okay. So a variety of issues that come up in terms of the hormone monitoring deficiency after surgery. So what does this actually look like in practice? What it looks like in practice is a person would come in after a pituitary surgery. They'd be having an MRI and blood tests, probably every 6 months, then every year thereafter. They might be taking some medication, usually pretty simple, and having blood tests to monitor what levels they're achieving with that, and then monitoring symptoms and things down the road. So again, early follow-up, maybe 3, 6 months, 12 months. Later on, just might be an annual thing for the pituitary. After the parathyroid surgery, again, might be a calcium value a week later, 6 months later, a year later. If it's a little bit low, might be some calcium and vitamin D tablets. I mentioned that parathyroid hormone injection probably coming pretty soon. Bone density testing. This is something that we would commonly be doing in people over 65 just because of menopause or other age-related concerns. But we might do it in a younger person with parathyroid concerns. And then a person, when we're doing a CAT scan or other imaging of their abdomen, maybe for the pancreas, we might kind of want to know what's going on with their kidneys as well in terms of kidney stone issues. Pretty straightforward. After adrenalectomy, this is the adrenal gland being taken out. Usually one, hopefully one. One's enough. This is a little bit tough for us. If both adrenal glands have to come out, more commonly in MEN2, we're talking about replacing hormones that are a little harder for us to replace, quite honestly, a little challenging. Very challenging to get the dose right. This is, I think, one of the areas in endocrinology where we hope to do better in the future. These are medicines you may hear about commonly, prednisone and hydrocortisone. Addison's disease, and people's adrenal glands, crash on their own. So they're certainly common medicines, just a little more tricky to use. What about the pancreas? I just said this before, how much is taken out? And Dr. Farley could speak much better than I can about, well, how would you know how much has to be taken out and which part? And thank goodness he knows how to do that because I would be in trouble. So it could be all in some situations. It could be partial. The pancreas has two big functions that you heard about this morning. I'm obviously interested in the blood sugar function, the insulin production function, but also nutrition as well, and it makes digestive juices and things for us. And so sometimes we need to be a little more careful with how people are digesting their nutrition and how that affects their stools or how that affects their vitamin levels. The good news is that we have better and better therapy for diabetes. So a person diagnosed with type 1 or after having a pancreas surgery that required them to have insulin therapy in 2014 is in a whole different situation than 2004, a whole different situation than 1994. It's actually pretty complicated to get all the technology and algorithms and math all figured out, but I'm totally confident it's coming. So it's good news, I think, for people who might worry about having to have a pancreas surgery at some point in their life, because I think we're going to do a lot better with the diabetes management in the future. The thyroid's pretty simple. We can monitor it very simply with an ultrasound. We can generally know what's going on with thyroid hormone levels. Pretty straightforward for most people. Can be a little bit more complicated when we're having to use thyroid hormone to treat thyroid cancers. So lastly, management other than surgery. I'd be curious as to Dr. Farley's reaction to this. I think I might even taken it from a surgical article, but surgery is not sometimes the first option, the preferred option, or not even an option. So one of Dr. Farley's most important jobs is knowing when not to operate. Not that, again, it's not our goal to cure people or our goal to resolve a problem, but sometimes surgery can be, again, kind of a mixed blessing in terms of what it might help versus what might be challenging about it. So we're always open to trying new things. This is where, again, Dr. Farley and I are blessed to work with a lot of colleagues in radiology and colleagues in other disciplines who are trying to find other ways to help us, whether it be affecting blood flow or affecting tissue size, for example. Maybe a radiologist might be able to treat a local lesion in the liver, for example, by freezing it or heating it or putting alcohol into it. This could also apply to the neck, perhaps. Maybe a radiation oncologist. We had a wonderful talk from Dr. Pollack the other day who does gamma knife radiation therapy to the pituitary, where he can give very focused radiation to the pituitary. We have some medications. Again, endocrinologists will definitely acknowledge that MEN is mostly a surgical disease. But there are some medicines we can use to block hormones that also affect growth of that tissue. sometimes we can try these sorts of things, especially in the pituitary setting. Cabergoline is the best example for prolactinoma. Sometimes maybe the tumor is benign, maybe it's not growing very much, we just need to kind of block its effect so it doesn't cause the symptom. In the case of gastrinomas or gastrin production, omeprazole or Prilosec is a good example. And maybe just focusing on treating symptoms. This is why this care team is so important. I think you've been hearing this all morning. Each person has something to add. I think one thing that people forget about the care team is the primary care provider. One role that Mayo Clinic can struggle with sometimes when people come from a distance is, again, coordinating care with that local provider who has that day-to-day relationship or week-to-week, month-to-month, including the fact that people who have MEN have other health issues that are not related to MEN1, for example. So we strongly advocate for the care provider, the primary care provider. A second reason is that sometimes people, when they're dealing with kind of a major health concern and appropriately focusing on it, kind of get out of the pattern of looking at preventative health, screening for other things that are common or just thinking about their wellness. I think a key thing here again would be, if I'm meeting with Dr. Farley, I'd like to be in good shape. So he's got someone who's well, who's fit, who's well nourished, has a healthy lifestyle, and could have a good healing from surgery. So I'm just advocating for the idea that although we were focusing this morning a lot on the MEN aspect of things, that overall health is really important, emotional health as well. So what are we going to do about that? Well, this is where primary care and other routine health care could be very important. I alluded to this before, surgical fitness and medical options. So the patient, this is my little moment to pitch an idea. When someone comes and sees me, it is my job to get their medical record straight. That's my job. I could use your help. I mean, we have open notes now where people can go online and look at their medical record. It's kind of a new adventure for us, but I think one nice thing about it is people can just help us out and say, hey, just to get that date right, this is actually when that was or where that was and what this was, and not worrying about every little thing, but that's helpful. Like events like surgery can be helpful. One thing I try to do when I meet with people is really kind of keep an itemized list of, well, what kind of screening have we done and when was that and what did we find? Help us out. It can be a little bit challenging sometimes to keep that all straight, especially if you've had care at multiple different places, for example, or maybe a test was done for a different reason, but that was good enough for screening. We should count that. The family history, as you heard a lot about, is something you can really help with quite a bit. Medications. We know that in many situations, medication lists are hard to keep. I'd also advocate for a medication list that's accurate, meaning it actually reflects what you're doing. So it's, again, I think hopefully a strong theme you felt this morning is a care team really does involve the patient, and a very comfortable relationship with the care team allows you to be very transparent about, well, what are you doing and why? And that's okay. Let's sort out why you're doing that and what we can do about it, and maybe it's good enough because you're making an informed decision, as the geneticist was just pointing out. So you could help with the medication list too. And then being well. This is my pitch again for the idea that being well helps us to help people work through those difficult times when they're having to have a surgery or having to have a diagnosis or a treatment. So taking care of oneself is another domain as well. Their emotional wellness, their mental wellness, their spiritual wellness as well. So these are my summary remarks. I guess you can call them as it relates to the morning, as you've heard a lot, but I'd be happy to take any questions you might have.
You alluded to taking good care of yourself physically and everything like that, but is there anything that helps retard the growth, the tumor growth? Is there something that you can do that's going to really help that?
So I was curious as the geneticist Mackenzie was talking about, skin exposure and cancer. When we think about tumors and growth, there's the seed and soil hypothesis. Have you heard of that hypothesis? So the seed is the cancer itself. The soil is the tissue it's growing in. It's the idea that if I'm a healthy person, if I'm fit, if I'm well nourished, that same tumor cell, otherwise exactly the same, has different potential to grow because the tissue hosting it is healthier or not as healthy. See what I mean? So if I'm not smoking, if I'm fit, if I have good nutrition, maybe that same tumor cell doesn't grow with the same potential, because this is a very common theory in oncology these days, whether it's breast cancer and et cetera. We hear spooky things from our oncology friends who tell us that we all have cancer cells in our body. They're there. It's just some don't actually ever get a chance to grow to any significance. Could that be because, again, other things are kind of slowing their growth or blocking their growth? Your immune system, for example, it plays a key role in doing that. Well, what affects immune health? Well, again, fitness, nutrition, etc. very complicated topic, but that's exactly what I'm thinking of when I'm saying, gosh, what could I do myself? I can't change my genes, right? I can't do an operation on myself. You wouldn't want to do that. So, but what could I do? Well, I could be well. I could be fit. The other part of it is that resilience factor, though, I think. We see people all the time who are dealing with hardship who have support and who are positive and who have, come in with a good set of resources like that, and they're going to do better. So the question relates to a person who has some pancreas tumors, who is receiving a medication called sandostatin. And my comment that I was making before about how some medicines don't just suppress hormone levels, therefore treat the symptom of hormone may be causing, but actually might affect the growth of the tissue that is making that hormone. And Dr. Farley may have some comments about this as well. So the medical term for the hormone that sandostatin is mimicking is somatostatin, or statin meaning stop growth. Somatostatin is a hormone that is made in a number of different tissues in our body, in the brain, in the pancreas. It has a general effect of slowing down or stopping growth or production of a hormone. Clearly, in the case of the pituitary, when people have things like acromegaly or too much growth hormone production, clearly giving that medicine doesn't just lower the hormone level, growth hormone, it can slow the growth or shrink the growth of the tumor. So that's the idea behind it. So I won't give an opinion regarding that particular person's situation because I would have to know more about that to do so. But that's a very good example of how the hormone itself the drug itself might not just lower the hormone level, might actually change the signal that might affect how much that tissue grows.
So in general, a person with pancreatic tumors, would you ever prescribe that?
It's most commonly used, I would say, when people are having symptoms and issues related to hormone overproduction by those tumors. So people who have pancreatic tumors who are not having symptoms and hormone overproduction, we don't typically use that medicine. Yeah.
You mentioned the difficulty or the frequency of follow-up if the hydrocortisone is being given. I had radiation following pituitary surgery here in 2008, and just this last April, they said I had bioadrenal insufficiency, and I'm taking the 10 grams in the morning, 5 at noon. How frequently, when I've just started up in April on the medication, should that be followed up?
So her question is a very specific question, but I'll try to generalize it so you can all kind of benefit from what she's trying to get at, which is a key point. She's having the concern about how, again, I had a therapy in the past that's now maybe showing some signs of hormonal deficiency in the present. A lot of our hormone therapies that we give, hydrocortisone or steroid can be an example, we don't have a blood test to measure to know exactly what we should give you. We don't. We don't have a perfect way of measuring in the blood or measuring another aspect of how the body responds to know exactly what's right for you. So a key part of the follow-up, especially early on, is seeing how you're doing, asking you how you're feeling. So we're giving this medicine, we're thinking about energy level, we're thinking about appetite, we're thinking about sleep and wake patterns and things. And for us to make adjustments to that, we have to know how you're doing. Now sometimes that can be a matter of just, again, a person saying, well, I'll let you know if I'm not feeling well. And if, as long as you're not feeling poorly, we say, hey, we're doing well. Very typically, though, what we're dealing with, though, is early on, you might be seen every couple of weeks, every month or so, to kind of keep making small changes and see, did that make the difference? Did that make the difference, for example? And then hopefully, if a person gets on a stable dose, they wouldn't have to have that intensive follow-up. So in the long term, it wouldn't be that rigorous necessarily. So her question gets to, again, a very general point that early after a surgery or once a problem develops, you'll be seeing your doctor more often than you might like, for example. But then once we get it sorted out, it's not usually quite that intense, and maybe go back into that surveillance kind of stuff and not so much the intensive treatment stuff. So, yeah.
I have a question about monitoring pancreatic tumors. In the past, I've gotten different thoughts from different doctors about MRIs versus CTs, and then I've heard other people say you really should be monitoring with an endoscopic ultrasound because the really small ones won't show up on an MRI or something.
Dr. Farley may add some thoughts to this as well. I think one key theme and why this is important to dialogue about is that sometimes a newer test isn't necessarily better than an older test. So people kind of have a perception, for example, that MRI is the greatest thing because it's the newer, fancier, kind of whiz-bang, kind of thing. a surgeon might say, well, actually, when I want to know kind of exactly this, or how much circulation's involved with this, or how much, I actually might prefer the CT scan. On the other hand, what about looking for things that are small? Well, maybe the endoscopic ultrasound might be important. So maybe we don't worry about small things from a surgical point of view if it was not making a hormone. Maybe we have a problem in the pancreas where there is too much hormone being made and it's causing lots of symptoms. And even if it's small, we have to find where it is. Well, then we might want to use a very sensitive test like an endoscopic ultrasound. Whereas that would be maybe not necessary in a person who's having no symptoms, hormone levels just fine, young, maybe for them a less frequent, less sensitive test like a simple CAT scan might be good enough. So
My concern is more about them doing it annually.
Yeah.
The accumulation.
it's an important question. I think we can also say we can provide information about that. Our radiology colleagues are very sensitive about that. Technology has advanced quite a bit in the realm of radiology, so the CT scanners they use now are faster and lower dose than they were 5 and 10 years ago. That's exactly why I put it in my discussion, because I know that's a sensitive topic that's coming up a lot in conversation. Is they give me this menu of tests. Well, why wouldn't I want that one? Well, there could be pros and cons to that we need to sort out individually. Yeah. Yeah.
What causes flushing and how can you stop it?
Flushing on the speaker's part, or flushing on the... Wow. Endocrinologists sometimes have long days when we meet people who are flushing, because there are so many different things that can cause flushing. So many different things. Flushing can be hormonal. Flushing can be lack of a hormone, the classic one being estrogen deficiency, right, in menopause. That's a classic one. But some other ones that can include some hormones that affect the vasculature and the vessels and how much they constrict and relax, that we can see in certain, for example, thyroid cancers. Flushing can also be caused by blood sugar issues. So we're dealing with people who are having issues related to that. Flushing can be, again, not hormonally related. It can also occur in relationship to things like panic, for example, and anxiety, a natural response to such. It's a long evaluation when we meet people with flushing. So certainly in the context of MEN, we think about certain tumors in particular. We'd say, well, that's interesting. We probably should think even more carefully because of this history. But we wouldn't want to miss the common things either. For example, like maybe we're dealing with menopause. So.
He didn't answer your question. Well, he did. It's a tough problem. Maybe next year's seminar will be on flushing.
Dr. Young loves to, he has a beautiful talk on flushing and evaluation of flushing, yeah, and so we could ask him to give that next year.
All right. I didn't realize that. That's great. Kurt, thank you so much, and thanks to everybody for showing up.